So, good morning, everyone. Bonjour, mesdames et messieurs. I'd just like to thank the conference organizers very much for what's been a wonderful 2 days so far, and in particular for having this panel this morning on health systems and for inviting me to speak. So I'll be talking about improving quality of newborn services, and I've deliberately taken a slightly provocative title, which is Crossing the Implementation Divide. So I'd like to begin with a quote from Margaret Chan, of course, Director General of WHO, because I think it really captures where we are this morning, which is the reality is straightforward. The power of existing interventions is not matched by the power of health systems to deliver those in greatest need in a comprehensive way and at adequate scale. And I think that's really what this panel and the next panel is about. And I very much appreciated the comments of my colleague about the importance of investing in health systems. So I'd like to make the case today that building health systems capable of continuously improving and sustaining quality of care is essential and will always be essential for achieving and sustaining effective coverage of high-impact interventions for every mother and child. And I've underlined the word improving because this is not a matter of closing a quality gap. It's a matter of continuously improving as new evidence becomes available and being able to improve across multiple technical areas, and it's also a matter of sustaining improved care. So the issue of quality in healthcare. This slide shows the cover of a report from the US that was published in 2001 by the Institute of Medicine, and they titled the report Crossing the Quality Chasm, and they were talking about the US. They're not talking about quality gaps here, they're talking about a chasm in quality. And so I come to you really to say that quality is all of our business, and that in fact, the challenges that we face around quality are global, and that some of the approaches that we can use can also be adapted in multiple settings very effectively. And you see this quote here, which I like, which I think is particularly relevant for a session on health systems, which is every system is perfectly designed to achieve exactly the results it achieves. Systems are complex, they're messy. If we don't change, if we don't try to pull that entropy in and to create processes and systems that reliably deliver the best, highest impact intervention packages for every patient when and if she or he needs it, we'll never have a difference in our results. So what do we mean by quality in healthcare? And I think, for most of us, as we should be throughout this conference, we're really talking about quality in terms of effectiveness of care, the degree to which care does or does not adhere with the latest scientific evidence. And we've heard throughout the last 2 days that just the huge explosion of evidence around high-impact interventions, and it's been just so exciting to be here. And to be a part of this and to hear so many individuals talk that I've followed for so many years in their work and publications. I'd also like to remind us, though, that there are other really important dimensions to quality. For example, safety. WHO has an entire department of patient safety and quality, and I'd like to just focus our attention a little bit on safety as an issue because achieving the best practices is, of course, essential, but we also know that there's a lot of harm that can be done as part of healthcare service delivery. We also usually talk about client-centeredness as a key component of all quality care, and I think there was a comment yesterday by one of the participants talking about the importance of attitudes of providers, et cetera, and this comes up throughout the world as a huge quality issue. And I think in maternal newborn care it's particularly important because we know that the degree to which care is client-centered probably it plays, a larger or lesser degree depending on the environment and the circumstances of the patient on the actual care-seeking behavior. And equitable. We've been talking a lot about equity in terms of coverage of interventions. I'd like to push us to think about equity in terms of does care vary in quality because of personal characteristics? Is care equitable in terms of the quality that two different individuals from different backgrounds receive? We know there are huge disparities, and they're not just about access and coverage, they're about quality. And I wanted to follow up on Cyril's wonderful presentation where he said and posed the question, how can we accept that half a plane load of newborns die every day? I'd like to ask us, how can we accept that in the aviation industry, there's a 1 in 10 million chance of an adverse effect? This is safety. Whereas 1 in 300 across the world. How do we accept this? That we can many of us get in planes and come here without really much worry, and yet we can't even deliver basic care without concern for harm, as well as meeting these best practices. Clearly, this is outrageous as well. And I'm not going to spend much time because there have been a lot of wonderful presentations and will be more about the quality deficits in maternal newborn care. I think most of us in this room were extremely exquisitely familiar with them. But I would like to just quickly show that, one of our main MDG5 indicators, and I know that there are many in this room that I've had this discussion with, is skilled care coverage. And I think many of us would say that this, while it is certainly perhaps an important indicator, it tells us nothing about the content of care. And this was a multi-country study done in 6 countries that looked at SBA competence using simulation and knowledge and a little bit of observation. And you can see that on average, we have about 50% compliance with a few key tasks. It's a much larger study, but I don't want to take the time here. And we know from other studies that we see the same thing. These huge, I would call them much more than quality gaps, they're chasms. And I'd like to share with you a couple of frameworks for thinking about how we think about improving quality. So we have on the left here the content of care, and that's really what we've been talking about the last 2 days, and it's at the heart of all quality and improving quality, especially if we're talking about effectiveness of care, that dimension. But unless we can link that content to the processes of care at the point of service delivery where patients receive services, we're not going to close that quality chasm. And this is another way of thinking about this. This is a framework developed by Batalden, who's done a lot of work in improvement and that's used a lot throughout the world, which is that we can think about key inputs, and they're vitally important, and we've spent a lot of time talking about them, supportive national policy, available, motivated, competent staff, essential commodities, up-to-date evidence-based standards, robust measures of quality, actual functional health management information systems. We know how hard it is even to get these inputs. But I'd like to push us a little bit to consider that these inputs alone are not going to produce quality care unless we connect them to the actual processes of care, the place at which patients receive care. And I think for those of us who are clinicians, this is quite intuitive, and that we will not have better outcomes unless we take it down to the service delivery level. So crossing the implementation divide, I'd like to make the case that improvement approaches offer us a way to begin to cross this divide and to take this content down into the point of service delivery and integrate it into processes of care. And there are many different ways to approach improvement, and I think many of us use lots of different methods, and in fact, I work in many parts of the world, including the US, and do routine improvement, and the best approach really, in my opinion, and I think in many people's opinion, really depends on the context and the needs. So I'm not here in any way to promote a QI method. QI as a noun, I think, is actually not very helpful. It's really about active improvement, but I think we can say that there are some key principles that in general do underlie much of successful improvement work. And one is this key notion of understanding healthcare in terms of processes and complex systems. The other is teamwork. And I think, a lot of the promising results coming out around use of checklists really leverage this key function that if you can bring together key actors as part of a team, actors that represent different pieces of a health system and of a process of care. So for example, if we're talking about maternal newborn, the midwife, the clinician, the nurse, the laboratory technician, the pharmacist, and bring them together around common objectives, that's how you ensure that all of those inputs come together at that point of implementation for that woman or that newborn who needs that care. And another key principle of all improvement is regular measurement of quality measures. Measurement, measurement, measurement is absolutely critical, because without measurement, we can have no idea of whether we're improving quality. And also the focus on patient needs. I'd like to just say a couple of words about measuring quality, because I think this has come up a lot, rightly so, during the conference, which is that we wish that we had stronger, more robust indicators of content, of quality, and I think a lot of us struggle with this, and there's not time to go into the challenges around measurement of quality. That could be an hour-long discussion in of itself. But I think the key message I'd like to make today is that we can actually measure quality, even in very low resource, highly constrained settings. It is possible. And that the teams that work at the service delivery level, and when I say service delivery, really I'm thinking almost at the district, sort of the slice of the system, from the district to the hospital, to the health center, to the community, they can target these high-impact intervention packages, and they can integrate regular measures of quality into their way of doing business. And so I'd like to just give you an example. This was a partogram in Niger, and I started out with URC based in Niger, and one of my colleagues is here who was very involved in this work as well. And we began to work on improving quality of integrated postpartum care, but the partogram didn't include oxytocin. It included oxytocin for augmentation of labor, but not for AMTSL. It didn't include many of the key features of essential newborn care. It had measuring head circumference and multiple APGAR scores, but we really wanted to focus in on these high-impact intervention packages. So local teams came up with this idea of just stamping the partogram, which then allowed, temporarily until we could work with, at the national level to improve the partogram, allowed this temporary measurement of quality. I'd like to thank Dr. Bernadette Daelmans from WHO, who gave me permission to use the slide that you saw in the first session, or maybe it was the second session at the conference. And we've been hearing a lot throughout this conference, and I very much appreciate this, the importance of integration of packages of interventions along key points in the RMNCH continuum. And I think for those of us who work on improving quality of care, this is very powerful because it is, in fact, these critical intervention packages at key points in a continuum of care that are exactly where we can leverage improvement approaches to close or at least reduce that quality chasm. And that, in fact, when we look at this continuum that Dr. Daelmans shared, we know that at the intrapartum point is where we have all of these interventions, both in terms of routine best practices for newborns as well as complications care. We also know that during that critical intrapartum and first day post-birth, we need to also include a whole nother set of maternal best routine care and complications practices. And that the challenge for the service delivery provider and the team that's responsible for that care is how to integrate all of that within, that critical moment of care. And this is where improvement offers, I think, a way to do that. And this is, I think, also why the WHO Safe Childbirth Checklist is so helpful, because the Safe Childbirth Checklist really focuses on that critical window of intrapartum, early postpartum, and it breaks that key window down into discrete phases: admission of the woman, labor, immediately after delivery, and pre-discharge, and it aligns these high-impact content interventions around those key moments. Once again, the process coming together with the interventions. So I'd like to just take us now and spend just a few minutes describing what this actually looks like if we take it down to the point of care. And I've titled this Improving Care Where Patients Receive Care, and I'm going to share just some examples from a few countries. And I think that often, we ask ourselves, well, how can we possibly, go around and work at the service delivery level? That's just overwhelming. We can't possibly, it's intensive. I'd like to challenge us that if we can invest so much in these, larger systems, inputs, and interventions, the least we can do is invest at that point of the implementation divide. And that if we don't do that, we will never substantively reduce that quality chasm. So this was work that, once again, began in Niger, and I'm just going to go quickly through a few countries. And we started out working in multiple sites, 28 maternities throughout the country. You saw the partogram that we had adapted, and we basically focused on this high-impact integrated package of the postpartum period. And you can see, we began with actually a baseline assessment using lot quality assurance, where, as you can see, compliance with some of these key ENC AMTSL was less than 20%. And this was just when a lot of the newborn evidence was starting to come out. And then as we worked with teams at the local level, and this is data aggregated across all of the maternities, we begin to see this increase in adherence, and we begin to see a decrease in PPH. And this was an approach in which multiple teams from different sites and system levels, because we had referral, district, and primary, and actually now we're working also at community in many countries, we're working intensively together to share and implement changes to their routine way of doing business to achieve better delivery of high-impact interventions. And here you see just an illustrative schematic that you have at each site a team, and now we also work at community, often where we bring in community members as part of a team, and each site tracks quality measures, and then those are aggregated across all of the sites, and sites regularly come together to share learning about the kinds of changes they made. And when we're working at quite large scale, we found that we can do this shared learning more at the regional or district level, and then periodically come together to synthesize learning. And so I've been talking a lot about how the changes have to happen at the service delivery level. So I'd like to just show some examples of the kinds of changes. When we began working in this Sahelian country, there was no designated place for newborn care in the delivery rooms. There was no warming blankets, there was no resuscitation equipment. Even now, we're still working on the resuscitation issues. There was no availability at the bedside for oxytocin for AMTSL. So, these were the kinds of changes that had to be made. And then this became synthesized in a learning session. And then we actually took this, our Niger team, and we have a member here, took this and we did this work in Mali. Mali started at a slightly higher level, partly because there had been so much investment already, and it was 5 years later, it was in 2010. And this is an example of doing this work in Afghanistan. And once again, it's the improvement team who owns the process, who tracks their own data, who's making the changes at their own level. And this is postnatal care. This is an example from Uganda. And I know we have several colleagues from Uganda here where we've been very privileged to be able to work closely with the Ministry of Health in 2 districts on ENC as well as HBB, and the idea of integrating coaching and mentoring. Once again, this improvement in adherence with best practices, adjusting local records. Again, this focus on it's the local team that owns the process. And the point that I'd like to make, and I don't want to end this presentation without making it, is that it is none of us sitting in this room that are going to be able to figure out what the solutions are to getting those best practices into routine care processes for every patient. It is only the people who work at the service delivery setting who have that profound understanding of their own systems and processes. And I do this in my clinical work in the US, it's the same process. Nobody can come in from the outside. I'd like to just end with, there's really not time to go into a lot of it, but that we can step up from a measuring system at these multiple levels of facility and regional and national, and we can move from a measuring to a managing information system, and we can do it at scale in maternal newborn. And we have been doing this in Ecuador, and I don't have time to go into it, but my colleague Jorge Hermida will be giving a presentation on this in one of the next sessions. I'd like to just end with coming back to this theme that comprehensive improvement approaches that target all levels of a health system, including service delivery, to deliver and scale up best buys vertical, in fact, help strengthen health systems horizontal and create systems that can continuously improve and bit by bit chip away at that quality chasm. Thank you.